All right. Good afternoon, everyone. This is Jay Reznick, and as part of what we're doing for our online oral surgery subscribers and dentistry in general, is we're putting together a number of live webcasts. And one we're going to do today is with someone I've known for quite a long time, since dental school, actually. Dr. Catherine Hayes received her BS degree in biology from Boston College, her DMD from Tufts University, magna cum laude, by the way. She completed a general practice residency at Brigham and Women's Hospital in Boston and received both master's and doctoral degrees in epidemiology from Harvard University, where she also completed a dental public health residency. And I thought I was in school a long time. Dr. Hayes is a diplomat of the American Board of Dental Public Health and is a past president of that board. She's a past president of the American Association of Public Health Dentistry and has held leadership positions in national and international organizations. She's published numerous articles in book chapters in the field of dental public health and epidemiology. Dr. Hayes is currently a clinical professor of health policy and health services research at the Henry M. Goldman School of Dental Medicine at Boston University. She's also a lecturer at the Harvard School of Dental Medicine and Director of Dental Services in the Division of Commonwealth Medicine at the University of Massachusetts. So kind of an underachiever, huh, Kathy? You make me feel bad, like I'm just some dumb country surgeon. So anyway, welcome, Kathy. It's really great to see you. So we've known each other since dental school, and I won't say how many years that is, but we met in our first year of dental school, and we've been friends ever since. So, Kathy, COVID-19, this coronavirus episode is called we're calling it a pandemic. So, what is exactly a pandemic as opposed to an epidemic?
So the simplest way to distinguish the two is that a pandemic really is a global epidemic. It's when there's a breakout of a disease that spreads readily across the population, and actually it spreads globally. So it's a worldwide epidemic.
Okay. So as an epidemic or pandemic, we hear in the news all the time, every day pretty much, about this pandemic or epidemic curve. Can you explain what that is a little bit?
Sure. If you want to show that first slide, Jay.
Sure.
So every epidemic follows an epidemic curve. It's, like many things actually in nature, we have a normal distribution. We have this kind of bell-shaped curve. Now, the curve on the left, which is more with the red shade, is your typical epidemic curve that we see. The whole idea of flattening the curve and looking at the curve on the right, where it's broader and flatter. So you don't see such a high peak. You see a peak that's more gradual, and so things are more spread out. Now, the reason that we want to flatten the curve, and especially in a case like this with COVID-19, is that many people who come down with this illness require hospitalization, and many require ventilators and ICU. So there's only a certain amount of that equipment that's available in the country and in the world. So what you want to do is to spread those cases out over a period of time that will enable the healthcare system to manage them. If we had this really sharp high peak, it would overwhelm the system and we would have many more deaths.
Okay. So actually you already answered some of the questions I was going to ask you, but that people
question. Theoretically, certainly the hope is the longer you can spread these cases out, parallel to that, there's efforts to come up with therapeutic regimens, for example. It's going to take longer for a vaccine, but let's say if, as you spread those cases out, people are able to find an effective treatment, or at least one that lessens the severity of cases. So you will hopefully see fewer deaths. You will probably see fewer cases, And that's why we have all the public health measures. But it doesn't necessarily mean that it wipes out the epidemic. It's spreading it out a little bit more
Okay.
to make it more manageable.
Okay. Great. And another one of the questions I was thinking about is what has evolved or changed in our understanding, our knowledge of COVID-19 since the very first case hit the U.S. In early January, and the first death in February. What do we know now that we didn't know? What do we understand compared to just a few months ago?
Interestingly, when this first came about and when the first cases were first discussed, like over in China and then some over in Europe, it was always thought of as a pneumonia-like respiratory illness. Like it was really concentrated in the respiratory system. What has happened since then is that it's been clearly determined that there are certainly vascular effects. There's a lot of problems with clotting, strokes. It impacts the kidneys. People have had severe kidney complications. It impacts the heart. And, we're seeing now, of course, children with this inflammatory condition that mimics Kawasaki's.
Yeah.
And we
Just
it's a
recently.
virus, right?
Yeah.
Yeah, just recently.
Yeah.
And it's a virus, and viruses mutate.
Hmm.
And so what I've certainly, learned, and everything is so new with this virus, so
Yeah.
we're learning so much, but it's believed that the virus that was in Asia did mutate. The European picture looks different than the Asian picture.
Hmm.
And the US cases seem to mimic the European cases more than the Asian cases. But I think what we're seeing is that we're continuing to see more and more of an impact from these, other sequelae, such as the vascular sequelae from this condition.
Yeah.
So it
Those
is
have become
respiratory.
major. Yeah.
Exactly. Exactly. Yeah.
Yeah. And I think now we understand a lot more why that's happening, especially in younger patients. And we'll talk about that a little bit too when we talk about risk factors. One of the things, if you watch the news and listen to all the pundits out there, everyone's saying, we're too slow to react. We didn't do the right thing. And you can be as critical as you want at a time like this. But my sense is that, this is a brand new entity, a virus we've never seen before. We don't know where it came from for sure. I just read something yesterday that's saying now a study out of China is questioning whether it really came from bats. How it spreads, who it affects, and how severe it is and how much of the population it's going to affect. We don't know any of this. And one thing that separates us from politicians kind of say what they want to say or what they think you want to hear. As clinicians, we're taught to say, I don't know. If I don't know the answer. We don't know the natural history of this virus. And my suspicion is that is probably the main reason, one, that we were kind of slow to react, and the reactions have been different, similar but different in every country.
Yeah. So, it happened so quickly.
Really quickly.
We do believe that it really quickly. And, it's not the first time that we've heard of, a virus in China causing respiratory symptoms. We've certainly had, SARS and other H1N1 that didn't turn into a pandemic. So I think that initially perhaps people were, well, let's just wait and see. But when it got to Europe and we saw how it was really impacting Italy, for example, that seemed to be the first hardest hit, and then France, Spain, and England, then I think people were starting to really take notice. That is certainly when I became aware, like, this is something more than an isolated respiratory virus in Asia. This is beginning to spread. But it's so new and so quick.
I mean, at first we thought it was only in people who had close contact with people who had come over from China. And then I think in February, got our very first community-acquired case. And I think that changed things a lot because, it changed kind of our model of how this is transmitted.
Right. As soon as you see community transmission, that is a huge red flag that for public health authorities that we have to do something now, because now people who have no other risk factors or no reason to have contracted this virus are getting ill and in some cases losing their life.
Yeah, getting very sick, and I have a colleague who, he's in his, I think, the late 60s, early 70s, developed coronavirus, was intubated in the ICU for about a week, and they tell him he's going to have 6 to 12 months of rehab, and he's shutting down his practice. He's done. And it's been really devastating to everybody, especially if you own a small business like a dental practice or medical practice. It's really devastating to all of us.
It is devastating.
And the effects of all this are so widespread. Let's talk about for a second for the modes of transmission. We hear about the droplets and sneeze and just normal breathing. They're starting to think that fecal oral route seems like that's probable. What about in our water, in our food? What's the difference between just breathing near somebody as opposed to having them sneeze or cough on you? And then how does all this relate to the 6-foot rule that we're all following?
Sure. So there's no evidence to suggest that it's foodborne. It is really believed to be airborne. And interestingly, what they're finding is these respiratory droplets can linger in the air. Instead of hitting the surface immediately, they tend to linger. The we have that 6-foot rule. That comes from the distance that the droplets have been shown to travel. It's believed that they can, if you and I were sitting in the same room now, and we were closer together than 6 feet, we could have that transmission. And you know what I find is a really interesting case is that the choir in Washington State, had you heard about that? So there was a group of, it was a church choir, and they decided to have their practice, and they, practiced social distancing. They tried to be very careful, but they were together for a long period of time, a couple of hours. There's a really interesting article, and it's, I think, had at this point over 13 million views just in the past week by someone named Erin Bromage, and he summarizes several of these points. And what he theorizes is that the reason that happened is, he said, things such as singing create a lot of respiratory droplets. And so these people were singing in proximity to one another.
Yeah, in an enclosed space.
In an enclosed space.
Yeah.
Those are the keys, Jay. Enclosed space and having prolonged contact. So those are the things, we see a lot of family clusters because they have prolonged contact, right?
Right, exactly.
Yeah.
So I've heard statistics, if you are walking down the street and you pass someone who's positive for coronavirus, I've heard the risk of transmission is like 0.05%. If you actually stop and have a conversation with them outdoors for about 5 minutes, it's more like 0.5%. So we're talking very small numbers. Now, if you have repeated contacts, it goes up as high as 10%, especially if it's a family member or someone you work closely with, enclosed in your office space or at home. And that's why we're seeing these clusters in families where we had one here in my area, in the hospital across from my practice in Tarzana. I think like a dozen guys went skiing, and 8 of them got sick, and I think 3 or 4 of them were in the ICU and really bad because they were all in proximity together for a long time.
Yeah, and so this is why the challenge of having people go back to work, because when you're in a workspace all day, and let's face it, the vast majority of people are probably asymptomatic carriers, at least at this point. There's plenty of asymptomatic carriers that we just don't know about. So if you're in a workspace with even one asymptomatic carrier for a long period of time, your likelihood of getting it is greater. I do believe, like, if you're walking by someone that's a very low risk, what they say is if you're walking together with someone for a long time and you don't wear a mask or exercise social distancing, you're at a greater risk. This is why masks are so important.
Yeah.
And I know a lot of people don't like wearing the mask. I don't really like it either, but
Yeah.
it's important.
Yeah. Well, they
Yeah.
just actually last night in LA, Mayor Garcetti mandated that anytime outside your home, you need to wear a mask. And, I go running most mornings, and when I'd run one particular path I do, I'd say maybe 50%, 50% of people were wearing masks. This morning it was more like 90. And I got to tell you, it's a lot harder to breathe with that mask on.
It really is.
I had to stop and walk
It
a couple
really is.
times. In fact, I actually, I've been watching some videos on, like ViewMedi, and then I don't know if you know Zubin Damaya, Z-Dog MD, if you're familiar with him.
Oh, you had told me about him. Yeah.
Yeah, he's great. So, I've watched some of his interviews and other I was going to say ViewMedi things. And one of the people that Dr. Z was interviewing was, I think, a cardiologist up in San Francisco. I think he's with one of the big health groups. And he was saying that, with his older patients with medical issues, overweight, heart disease, diabetes, etc., when he first gave them a mask to wear, or they first started wearing a mask all the time, and they could barely walk a block without getting short of breath. And after a couple weeks, they could go a block or two with no short of breath. And after a month, they could go 3, 4, 5 blocks without short of breath. And the theory is just like with those high altitude masks that you wear if you're training for a sporting, like a marathon at high altitude. By making it more difficult to breathe, you're actually increasing your red blood cell count and your oxygen carrying capacity. And so I'm like, okay, well, maybe it's a good thing, even though it was a pain this morning. Yeah.
Yeah, it's definitely takes, even though we're used to wearing them clinically, when you're exercising, it's a different story.
Well, clinically, you can't wait to take them off, and move on to the next patient or the next consult.
Exactly.
So we've talked about the risk of becoming infected having to do with the amount, kind of the inoculum size versus the exposure time and whether you're in close proximity. And so we hear about these families getting sick. And in some families, everybody gets mild symptoms or no symptoms, even though they may test positive and they're fine. In other families, they may all get really sick and end up in the ICU and die. Are there genetic differences that make more people more susceptible to the deleterious effects of coronavirus, such as the cytokine storm, out of control immune response? Is that something that you think is genetically programmed?
That is a good question. I honestly don't know. What I think has been the case in many of these cases has been more other conditions, whether it's hypertension or diabetes or obesity, the similarities in these other conditions amongst family members. But I think the question about the immune response is an interesting one, and I'm not sure about that.
Yeah, that there's this variation. And so, we know now that coronavirus seems to attach or get into cells through the ACE2 receptor. And so we think that's why we're seeing obese patients who have more, and it seems to be associated with belly fat, not like if you have fat arms or fat thighs, but if you have belly fat, that I think increases your number of ACE2 receptors and also some of the interleukins. And then, of course, with the hypertension, probably the same thing. Diabetes is probably a very similar thing where you've got kind of an up modulation of some of your ACE2 receptors, and that may make them more susceptible. What are your thoughts on that?
Yeah. Well, it's interesting. I mean, I think people have certainly made that argument. It makes a lot of sense. And the other interesting thing that I've seen just recently was that they don't see a lot of asthmatics having serious illness. And there's a theory that's related to what you were just saying as well. So it's interesting.
Yeah, I've got a friend who's asthmatic, and he got sick twice. He lives in New York City, and got sick twice. Finally got, and they wouldn't test him for coronavirus either time because he didn't have a fever, but he had all, he had all the symptoms. Well, he felt crummy, and he had, a little bit of a cough, but never any shortness of breath, never a fever, and he subsequently tested positive afterwards. And so everyone was worried, being asthmatic, that he was going to be more susceptible. And I think, you're right. We're seeing that asthma, you would think, would be a risk factor, and it doesn't seem like it's turning out to be that. So that's interesting.
Exactly. And clinicians have been commenting that they're not seeing as many asthmatics as they would have expected. So it's an interesting avenue to explore.
Yeah. And speaking of testing, how reliable are these viral antigen tests and the antibody tests? And how are we doing in developing new tests that may be better, more specific, lower false positive, false negatives, so that we can really rely on the result that we get and know what it means?
Yeah. So there's been like an explosion in the number and types of tests. And they say the most reliable one is the swab, and people describe it as you almost feel like it's touching your brain. It goes so far up the nasal cavity.
Yeah, to get a good sample, you actually have to go through the nose all the way back to the back of the pharynx. So some of these places where they have you, the drive-through testing, where they give you this stuff and tell you what to do, I doubt anybody's really getting that far back. Especially if they've got large turbinates, that they're not going to get back there. And I've seen studies that look at the accuracy of, or at least the antigen positive rates in the different types of testing and where the testing sample comes from, and it's really variable, especially nasopharynx and
Yeah, they do say that, the one that really goes back, that is the most reliable. And, ideally you want a test that has good sensitivity and good specificity. So that means if you have the disease, you want it to test positive. And if you don't have the disease, you want it to test negative.
Yeah.
And I think the test with the best is the antigen. So the antigen is that it's like the foreign substance that the body's reacting to.
Right.
So the antigen test is actually looking for the virus itself.
Yeah.
So some particles of the virus. The antibody test is more our response to the antigen.
Yeah.
So
and that takes like a month or so to develop, doesn't it? To get the IgG response. Yeah.
Exactly. And they're saying that some of the tests, and just full disclosure, I went to France in late January, and when I came back a week later, I had pneumonia. And my PCP wants me to get an antibody test, but she wants me to wait another few weeks because there's some better ones coming down, as we say, down the pike in Massachusetts.
And I guess we don't really know how long your antibodies, IgG, will be positive, and we have no clue about whether that's going to give us immunity to get sick again, right?
Exactly. So we don't know if that's going to give you immunity in the long term. So everything's new today. There's so much, everything is new, and I feel like we're learning something new every day.
Yeah. We just don't know. So let's get back to face masks again. I've seen studies comparing. Everyone's talking about you have to have N95. There was a study by Radonovich in JAMA last year where they looked at healthcare workers who were taking care of flu patients, and over 4 flu seasons and 137 sites. So this was a pretty big study, and
included dentists too. That included dentists, I believe.
Yeah. Okay. And they, they look, and some of the healthcare workers had N95 masks, and some of them had just used level 2 or level 3 masks. And what they found was that there was no difference in the infection rate against these healthcare workers against the flu. And then Ng, just a couple of months ago in Annals of Internal Medicine, looked at 41 healthcare workers who were working closely in close proximity to a patient in the ICU with COVID. And I think 85% of the people had a regular surgical mask, level 2 or level 3, and 15% had N95 masks. They had other PPE too, and none of them got infected. So,
Yeah.
what are your thoughts on the different types of masks and
Yeah.
PPE?
Another great question. The one concern I had about the larger scale study, I forget the author's name, begins with an R.
Radonovich. Yeah.
Radonovich.
Yeah.
It was a really well-designed study. The one concern I have when I was looking at their sample size calculation, so when we design a study, we design it with a predetermined number of individuals that must be in the study in order for us to detect a difference that's meaningful at a certain statistical level of significance. It's pretty standard,
The
right?
old p-value.
So, yep, and we get a p-value. So what I looked at in that study was, so here's the other thing. If we don't have enough people in the study, what can happen is we get this false negative, and we call it a beta error. So beta is, when you find that there isn't something when in fact there really is. So I'm a little concerned that the number in the study, even though it was huge, may not have been large enough to detect the difference. So I always have to put my statistical hat on.
Yeah.
So that I have one little question about that.
Yeah.
The case study, as an epidemiologist, we're always like, case studies are interesting, but you can't really conclude anything because it's just one patient.
Exactly.
So, it's another one of these questions, Jay, where I think we're learning as we go along.
Because I think it's adding to our knowledge base, but not
absolutely
giving a definitive answer.
But it's not definitive, right?
Okay.
So with that, if it were me as a clinician, I think I would do as much as I could to protect myself. Mm-hmm. And as we learn more, things we may find that we don't need quite as much. But I think it's better to err on the side of too much than too little PPE.
Okay. In my office, in my office, we ordered N95 masks 2 months ago, and we're still waiting for them. We've got a huge supply of level 3. We've got running low. We've got cover gowns, although we're running a little bit low. And I got a couple hundred face shields that we wear over our masks. So, and we're hoping at the N95s. Actually, I just got some KN95s delivered yesterday, just 20 of them, until we get the N95 order, which supposedly is on the way. What are your thoughts? What does the literature show about how much we can reuse our PPE because of the shortage? Because this is something that our patients and my office team want to know too.
Sure, absolutely. Now, theoretically, N95s and all masks have been discarded after each individual patient. Here in Massachusetts, they invested in this. There's actually a facility just outside of Boston that cleans and sterilizes N95 masks. So the governor purchased that for the state, and the hospitals and others have contracts to get there, and they're sterilized. So it's a really state-of-the-art system. So it is possible, but you would have to have... Are they doing
that after every single use, or how often are they having them sterilized?
That I'm not 100% sure, and I think it varies, Jay. I think it really varies.
Okay. Now, what if you have a face shield? Or what if you wear, let's say, a level 1 mask over your N95?
So some people are doing that. So
is that a good strategy?
N95. I think, I'm reluctant to say because we don't have the evidence. However, I think if it makes sense and you're comfortable with it for now, as long as you're protected.
I think we don't know, and we don't know for sure, and we've got to do what makes sense. If we have a shortage of N95 masks, if we just can't get them, we're going to have to reuse them until we can get the supply comes back up.
I know. Our governor has ordered so many of these masks for hospitals. It's quite remarkable the extent that our governor has gone to get N95 masks for our hospitals. Because Massachusetts has been hit pretty hard, so we have a lot of cases here.
For sure. In California, we just have a lot of people, so we have a lot of cases too. A lot more than we do. So one of the other things that we talk about as a way to prevent, spread of the infection is avoiding touching your face. And I just touched my face before I asked you that question, but I've been thinking about it. And I saw a couple studies. Kwok in the American Journal of Infection Control way back in 2015 did a study with, I think, 26 medical students that were all highly trained in infection control procedure, as well as, don't touch your face. And I think in a study, it was an average of like 25 times per day that these medical students were touching their faces. And then Rebman, in the same journal a couple years earlier, had done a similar study with ICU nurses caring for flu patients. And these were nurses wearing N95s and all the PPE. And they found that these nurses were, in their 12-hour shift, were touching their faces, even though they knew not to do it, about 23 times an hour. It's just, it's crazy.
It doesn't surprise me.
Yeah, because I see people all the time adjusting their mask, and especially, we'll talk about this. I guess I may as well bring it up now. People who are wearing gloves, you see them around wearing surgical gloves, and
you're talking about like the lay public, not a clinician.
The lay public, not. And I just think that's the dumbest thing. To be wearing masks out in public. I saw a lady in the grocery store last week. She was wearing an N95 mask, and she looked fairly young and healthy, although you can't always tell by appearances. N95 mask, a face shield, her head covered, and rubber gloves to go grocery shopping. And then I see her adjusting everything. So, I think one thing the gloves do is they give people a false sense of security.
I totally agree with that.
They're touching their face probably more often than someone who doesn't. And, I wash my hands at least twice an hour. In the office, it's more like, 5 times an hour. But when I'm staying at home, at least every probably once or twice an hour. I doubt people who are wearing these gloves are taking them off after every encounter and putting on new ones. And if they are, they're taking gloves away from healthcare workers who need them. But if they wash the gloves and wear them, let's say, all day or even for a week, every time you wash the gloves, especially with soap, you're breaking down the integrity of those gloves. And I haven't heard anybody talk about that.
I'm glad you raised that issue. And then the two issues that you raised, I want to underline, is the touching the face and washing hands. Now, as I touch my face, it is this human. I remember when this first came out, like, don't touch your face, and people were saying, oh my God, I had no idea I touched my face so many times. Because people were starting to notice. And I remember that, I don't know if you remember that movie, I think it was called Contagion. And I remember when the epidemiologist comes to talk to the people about the outbreak, and she said, do you know people touch their face like 1,000 or more times a day? We touch our face a lot.
Now I'll have to watch the movie.
More we bring it into, now you got to watch the movie. So the more we bring it into our conscious awareness, limit the touching our face, especially the mucous membranes like our eyes, nose. So that's one thing. More important than wearing gloves is washing hands frequently.
Hand
so anytime you go to the
soap,
store, you come home and you wash with soap and water. Sing the happy birthday song twice. I teach my little granddaughter, we sing happy birthday twice, and that's the length of time that you need to wash your hands.
And when I walk out of the grocery store, first thing I do before I put the key in, put on my seatbelt, is I've got some hand sanitizer. Because we have some surgical hand sanitizer we use in the office, so I put some in some little bottles. I will sanitize my hands before I touch anything in the car, and then when I get home, wash my hands for like 20 seconds. And I try not to touch my face. But there are so many people that are so paranoid out there, and they think that wearing gloves is going to make a difference. And even though they're told not to touch their face, don't wear gloves, wash your hands every hour at least, or after every encounter, and don't touch your face. They seem to again the wearing gloves, and if they get an N95. Which is, all these people, all these lay public people with the N95s, they're the reason that healthcare workers can't get them for treating patients.
Yeah. Yeah.
And that's a little another pet peeve. But I think
A cloth face covering is fine.
Yeah.
For the general public, a cloth face covering is fine.
Yeah. That's I think that's more than adequate.
Yeah.
So, how far are we from a vaccine for COVID-19? I've heard, a year, 2 years. What are you reading, and what are you hearing?
Yeah. I mean, I think, from the very beginning, Dr. Fauci talked about, 18 to 24 months, that's even a rapid rate. Because as you know, any type of new drug or vaccine has to go through multiple phases of clinical trials. You first have to test its safety on animals, and then you have to test safety and efficacy in humans, and then you have to do a clinical trial where you use a placebo or some other, whatever the other things you're going to test it against to test its effectiveness and its safety. So those things take time. Now, I think that one of the things we have in our favor is that this is an illness. It's not like a chronic disease where we're looking at something like, heart disease or even breast cancer, something that takes a long time to form. So we have that working in our favor, but to get through those multiple layers of testing, I mean, a minimum of 18 months, and that's even like really optimistic. But I mean, not before 2021 for sure, Jay.
Okay.
Not before 2021.
Okay.
I mean, unless there's some miracle that happens. But even if it's the most perfect vaccine, you still have to test it, right?
Yeah.
And that takes time.
Yeah. I mean, given the devastation that coronavirus, COVID-19, has done to the entire world, the world's economy, do you think there's any way that getting the vaccine will be mandated if you want to go to work, go to school, be out in public?
That's a good question.
I know with flu vaccine, there's we have all the anti-vaxxers who put themselves and their kids at risk. But certainly the flu hasn't wiped out life as we know it in the world like this COVID-19 has. So you wonder, all the policymakers, if only half the people on the planet get vaccinated, what is that going to do in the future? And of course, then are we going to have an annual vaccine if the virus mutates every year?
I know. It's interesting. I mean, we have to get a flu vaccine every year. And I know in terms of mandates, one of the roles I have is at Boston University, which is a very large university of 30,000 students, faculty, staff, right? It's mandated that we get a flu vaccine every year, and you do it.
Yeah, same thing in my hospital.
But,
And actually,
so
if you don't get a flu vaccine, you're not allowed in the hospital.
Same in these clinics as well. I think for the general public, I mean, that's related to, safety for ourselves and our patients.
For spread.
I think exactly. I think it would be harder. Look, people are having a hard time with the stay-at-home recommendations, so they're going to have a hard time with a mandated vaccine, right? But I hope that
getting a vaccine is a lot easier than staying at home, 7 days a week.
Right, exactly.
And going nuts.
Exactly.
Yeah.
Unless
you like to read and do jigsaw puzzles.
That's right.
Which we're on our 5,000 piece puzzle. We started last night. Oh, I know. So, what do you see as the long-term impact of COVID-19 on the way we practice dentistry? I know in my practice, I've been going in. We've been scheduling Mondays and Friday mornings to see emergency. So I've triaged them on the phone and then put them either Monday or like Friday or the next Monday. And we're planning to go back full time, tomorrow. But our schedule is going to be starting out Monday, Wednesday, Friday mornings. And we're having trouble filling the schedule. People just don't want to come in. They don't have the money to spend on, getting their implants done, getting their kids' wisdom teeth out. And they're putting everything off. Now, eventually they're going to come back, but with all the social distancing guidelines and everything else, I don't think we're going to be able to see as many patients in a day. I think our production our ability is going to be like half of what it was, or, less than 2/3 of what it was. And,
it's very concerning. I have a lot of
really concerning.
concerns with the dental profession. It is very concerning. And, for example, a general dentist even might have multiple chairs where they might, give a block, and then while they're waiting for that block, they're working on another patient, and then the hygienist in another room. And now, because of, all the PPE that, it's not just a mask, and goggles anymore, right? It's the gown and everything else.
It takes time to put those things on, and
it does. And the social distance. So I have a tremendous amount of empathy and concern for the dental profession, because I think it's going to be a profession that's really going to be hit hard. When you and I were graduating dental school, there was another epidemic, AIDS. And dentistry
so you just dated us.
So.
But I remember when we started dental school, nobody wore gloves.
Right.
Yeah.
And then universal precautions came about.
Yeah.
And I mean, I think dentists are very careful about infection control. And they're very well educated and practice excellent infection control.
Absolutely.
And so now it's going to be another added layer, which, Jay, I wish I could say that this is going to be just for a short term, but until we have effective treatments and a vaccine or significant immunity in the population, we're going to have to exercise this level of care.
No, it's going to be 2-3 years before we can get back to anything close to normal. In not only in our offices, but in the whole entire world economy. What do you think about? We're going to have to make a lot of changes. Obviously, we're going to have to space patients out more. We're going to try to have no more than I've got a pretty big waiting room, 3 consult rooms and 2 surgical suites, and then a 3-bed recovery. We're going to try to have no more than 2 people, like family member groups in the waiting room at once. We're going to try to get people right into the consultation rooms as fast as we can. I'm looking at putting barriers between each bed in my recovery room.
That's a good idea.
So those are changes. But then there's the whole unknown of, is someone coming into your office for surgery asymptomatic carrier of COVID-19? What do you think? Do you think we're going to need to be able to do rapid testing in our patients before we treat them? And maybe not for the consultations, but before we render any treatment. Do you think that's going to come to fruition? And what type of tests are they developing that will allow us to do that economically?
Yeah, I know exactly. So that's a good question. Will dentists need to do that testing? And as we know, no test is perfect, right? And I don't know that these rapid tests have the same level of sensitivity and specificity, the same precision as
they're all
the more invasive.
Yeah.
And then the cost, as you say, as well. Yeah. I know, for example, at the university where I work as well, some of the laboratory staff are going back to work starting next week, but everyone has to be tested before. So they're being, tested at the university hospital and all of that. So, that obviously is different than if you're in a private practice having to bear that expense on your own.
Yeah. But if they're going to be coming to work every day, are they going to have to be tested every couple days?
So that's the question too. I mean, theoretically, no, but how often then do you space?
Am I going to have to, test my staff every 3 days?
Yeah, and that just seems prohibitive cost-wise.
Yeah, it really does.
Time-wise.
It really does. I mean, our overhead we see going through the roof because of all the PPE and everything else we have to do, and our production is going to be half of what it was at best for a long time. Another thing that people are talking about, and I'm looking into for my 2 surgery rooms, is creating a negative pressure environment that will suck all the air out, hit it with ultraviolet and then with a 99.99% HEPA filter before it exhausted up to the roof. I've seen some of these dental vacuum things that they're selling that exhaust into the room, but probably after being treated. Do you think that is going to become a standard of care? Are we going to be able to treat our patients without, again, making that investment for patient safety and our staff safety?
So, yeah.
What are you hearing?
It's an excellent question. I think, again, I always like to make sure there's evidence, especially if you're going to be asked to invest so much into these. I mean, these things are costly, as you know.
Yeah, we're
so we want to know that they're effective, right? And that they're necessary. And we're not there yet. We don't have that information yet. Theoretically, what you just described, that sounds like it would really make a huge difference.
Yeah.
But if it doesn't, if it's not any different, or it's only marginally better than what you do traditionally, it's probably not worth it.
Yeah.
One of the things they're saying is, you treat a patient in one room, finish that up, and you go to another room, but you can't use that first room for a period of time until the droplets have time to be cleared.
Yeah.
And again, Jay, we're at the beginning of this, so there's so much unknown.
Yeah, I mean, theoretically, it sounds like it's something we may need to clear the room, as well as sanitize it before we get another patient. I mean, we're used to doing surgeries every 30 minutes, back to back. Especially on Friday morning, I may do 6, 8, or even more surgeries under anesthesia in a morning. We're just not going to be able to do that. And I guess my other thought is, with some of this negative pressure and dental spray vacuum systems, patients may be hesitant to have anything done if we don't have those in our office. I think the investment, not just from a theoretical standpoint that it seems like it's something we need to do, but that I think our patients will come to expect that for their safety, and again our staff too. And my feeling is if we don't, and I certainly don't want to dictate what everybody does, that we may be at a sort of competitive disadvantage against the other clinicians, other specialists, other GPs if they have those systems and they let it known that they do and we don't.
Yeah.
Or am I just fear mongering?
No, I mean, I think, you have realistic concerns, and none of us know the definitive answers to any of these questions yet, Jay. And I think that the more caution we can exercise, and the more, stringent infection controls in that relationship with the patient, ensuring that you're taking care of their safety and well-being as well. And we're going to continue to see this evolve in terms of guidelines, because right now the guidelines are,
we don't know. We don't know for sure. Exactly. We're just making our best guesstimate. Okay.
Right.
Great.
Yeah.
Well, we've been talking 48 minutes and 38 seconds.
Are you kidding?
Yeah, it went by fast. So I guess just kind of wrap things up, because I know you've been telling me about your schedule and how busy you are. I don't want to hold you any longer. This is not going to go away for a long time. I think we're going to have to totally change everything. This is changing the world as we know it. And we're just going to have to adapt to it. Hopefully N95 masks and other PPE will become available. But I think, if we do the best we can. If we have a level 2 or level 3 surgical mask with a face shield and the other PPE, we got to do what we got to do until we get that. And don't touch your face. Be aware of it.
Don't touch your face. Wash your hands.
Wearing gloves out in public is stupid. And that really we need to understand that just because you walk by someone or in a room for a minute with someone who may be infected, whether you're going to get infected really does depend on the size of the inoculum, how long you were exposed, and
Mm-hmm.
individual variation, just like everything else in medicine.
Yeah.
Everybody's different. And I
Everything's
think if
different.
we can disseminate those things, I think
Mm-hmm.
we've done not only our fellow clinicians a service, but I think hopefully a lot of people in the lay public. I've got almost 5,000 friends on Facebook, so hopefully a few of them have been watching this. That we can help reduce some of the paranoia that a lot of people
Yeah.
have. So, what
Mm-hmm.
would you like to
Yeah.
say to wrap things up?
Well, what you just said, knowledge is power, right? The more we can
Mhm.
understand this, the more informed we are as individuals, as clinicians, the safer
Yeah.
we're going to be.
Yeah,
And
it's
I
funny. I
think
have, I have a
washing our
sign. I have a
hands,
sign in my office that says that knowledge is power. So,
really, isn't
yeah,
that funny?
yeah. It's
But
it's
it's so
uh,
true, right?
it's so true. Yeah, exactly.
Yeah.
Yeah,
And really getting, sound information and not the hysteria, but sound information from people who really know what they're talking about. And the most important thing we can do is wash our hands and not
yeah.
touch our face. Those are the most important. And
Exactly.
social distance. Those
Okay.
are the most important things. Yeah.
Great,
Thank you,
Kathy.
Jay.
It's been incredible talking to you.
Likewise.
And you've got insights that, as a dumb country surgeon, I certainly don't have. And I
I
really
would hardly
appreciate
call
you.
you dumb.
I really appreciate you taking your time out of your really busy schedule to chat with me. I really appreciate it.
My pleasure.
Thanks,
Thanks for
Kathy.
having me. It was
All
really a
right.
pleasure. Thank you so much.
All right.
Bye-bye.
Bye.